Services Act Administrator for RUHSBH. And my central job is kind of like a compliance officer. It's my job to make sure that we follow our MHSA, our Mental Health Services Act regulations. And a part of those regulations is our community participation process, which means we formalize at the start of the year, going out to some of our community partners and advisory committees and giving them an update on what's happening in the county's Mental Health Services Act plan, and to give you some further education about the plan itself and how you can become involved as a stakeholder in participating in this process. Time willing, and I think if I've planned it out well, I will also be giving you an update on the Behavioral Health Services Act, at least a snapshot of that. The proposition that was Proposition 1 in the March ballot that just recently squeaked by and passed. So some things to anticipate as we begin trying to steer the ship in the direction of that new legislation. Some of you may remember these kinds of presentations from the past. I think I visited last year. So some of this might be a little bit familiar. So for some of you, it may be review, and others, it might be a new introduction. Go ahead and go on to the next slide. So what is the Mental Health Services Act? It was a proposition in 2004, was Proposition 63. It's a 1% tax on incomes over $1 million dedicated to the public mental health service system. That tax structure under BHSA doesn't change, and so it hasn't changed anything about tax revenue in going to BHSA. That tax system is the same. How the funding can be used is going to look different, and I'll talk a little bit about that when we get to the BHSA section. MISA has rules and regulations on how the money can be spent. So it's not just a kind of pot of money the county can use. It has to follow the specific regulations or the rules outlined in legislation. It cannot pay for most involuntary programs. So programs like hospitals, other kinds of involuntary care like in detention, has some very strong restrictions regarding the use of the dollars. It is the funding of last resort, which means that the state wants you to look at all the other potential funding that would be able to fund a program before using MISA dollars. And so what happens is a lot of time MISA dollars are used in a braided fashion, just like think of it like a hair braid. Each one of those kind of chunks of hair is a different funding stream, and they braid them all together to be able to create one funding stream or one funding source for a program or project. As indicated earlier, MISA regulations include a community participation and planning process. Some of that is regulatorily defined, but we accept feedback all year round. Because of that braided funding, department program development and MISA planning coincide with one another. So we take feedback all year round from folks and looking at services in order to be able to kind of inform how programs should be developed to meet community need. But this is the time of year that we formalize this process for this particular regulation, where we're able to get your feedback and ensure you have the information you need to participate in the upcoming public hearing and postings that we're going to have. Go ahead and move on to the next slide, please. So what is the MHSA or MISA plan? Essentially, it's a big report. It's about 500 to 700 pages long, and I know because I get to edit it. And it's a report that's used to show the state that we confirmed to regulation. It's also available for community review, so the community can see what's in the plan for transparency. It also shows the state that we had authorization for these expenditures from our Board of Supervisors. As indicated earlier, though, it does not represent all of behavioral health funding, and so not all behavioral health programs are listed in the MISA plan. And that's why, though it has a lot of programs listed in it, it can't really be used as a guides for services because it doesn't have all the programs in it. You can go on to the next one. And there are two different types of MISA plans. There is a 3-year plan, which works a lot like just what it says. It's looking at goals over a 3-year period of time. And then there's an annual update, which is like a progress report on each of those individual years. And we are currently doing an annual update. The last 3-year plan has those fiscal year dates displayed on the screen. Go ahead to the next slide. In addition to stakeholder feedback, the department's planning is informed by several other sources. That includes a lot of data and research, state, federal, county data. The department has its own research and evaluation team, and we look at the department's outcomes on programs and areas in which we need to develop capacity. And then there's trending needs, some of the stuff that we're currently going through, like the continued opioid crisis and things like COVID, which impacted folks' behavioral health, and being able to integrate some of that programming into services as well. But primarily, the programs in the MISA plan are rolled over from year to year as a way of trying to avoid service disruption. Yet community voices, feedback can alter the plan in ways that develop new programs, reinvent new programs, or terminate programs. You can go ahead and move on to the next slide. So what does MISA kind of look like in a snapshot? That's MISA in a snapshot right there. It essentially, think of it like a book that has chapters, and each one of those chapters is specifically designed to address a different need in the public behavioral health system. So we're going to go over each one of those chapters or components, give you a little bit of information about that, and then an update in the plan regarding something related to the Riverside County plan. So go ahead and move on to the next slide. The first component is called Community Services and Supports, or CSS for short. It is the largest of the components and receives the most amount of money. About 76% of Riverside's allocation goes to the CSS component. It establishes a high-intensity therapeutic and case management program called FSP, or Full Service Partnership. Regulations indicate that 50% of the CSS dollars must be spent on full service partnership programs. It also allows for clinic expansion to improve capacity. It was the integration of all our peer support and lived experience practitioners into our programming. And it allows us to extend the amount of employees at a particular site in order to be able to serve more people. CSS includes, especially for this group, it includes all of our Housing and Hope programming. Even though Housing and Hope is braided, there's grants and other funding in it. CSS is one of the major funding sources for our Housing and Hope programming, as well as some of the capital projects that are built for our Housing and Hope projects, like some of our housing developments. It also helps fund our crisis system of care, some things like our mobile crisis teams and our urgent care centers, and our justice involved programs like the collaborative courts and some of our forensic outpatient and outreach services. Each of the components has like individual work plans within them in order to kind of give them structure. And you can see there on the screen, the structure for CSS is full service partnership, that general service development and expansion, outreach and engagement, which is most of our peer services, and then again, that housing component. You move on to the next slide. So what are some updates in this year's plan, or some on the progress report? For those of you who may not know already, our Riverside County's mobile crisis response teams are now available 24/7. The mobile crisis response teams include clinical therapists, case managers, addiction counselors, and peer support specialists who respond to behavioral health needs in the community. The mobile crisis teams are countywide and have successfully diverted 70%, that's 70% of contacts from law enforcement and acute inpatient admissions. Anyone now can contact to have a crisis team dispatched for somebody who's in behavioral health distress. And that phone number is 951-686-HELP. Those folks will then screen the call and hopefully connect you to the right resource depending on what the actual need is. And sometimes that will be a crisis team to come out and help somebody or review their current circumstance. All right, go ahead and move on to the next one. The next component is prevention and early intervention. It is the second largest component, PEI for short, receives about 19% of the MISA allocation. Its goal is to reduce stigma for people seeking services, reduce discrimination against people who carry a diagnosis, and prevent the onset of a serious mental illness. It also includes early intervention for people with symptoms for less than 1 year, or who do not meet a criteria for a behavioral health diagnosis, or who can benefit from low intensity or short-term interventions. By regulation, 51% of the PEI dollars must be spent on youth or their families under the age of 25. You can see Riverside's work plans there listed on the screen. They were originally developed out of an intensive community stakeholder process with focus groups, and then also, again, data, especially county risk data on areas that might be at greater risk for behavioral health outcomes. So you can see, again, those 7 different plans on the board. And I'm going to go over a highlight in a minute. Go ahead and move on to the next slide. All right, yeah. One of the highlights in the PEI plan comes in from work plan number 1. Prevention and Early Intervention is the co-chair with the RUHS Public Health for the Suicide Prevention Coalition, which is a Board of Supervisors directed coalition to address suicide in Riverside County. And that coalition, in partnership with PEI, will offer short-term grief counseling for survivors of suicide loss at no cost to Riverside County residents. Family and friends of loved ones who have died by suicide are also at high risk to attempt suicide themselves. This pilot will offer 6 to 8 free sessions to suicide loss survivors through community-based clinicians trained in suicide bereavement. Applications are being accepted continuously until a sufficient number of providers are obtained to address the need. So if you are a therapist or know a therapist who may be interested in being trained in the model and to provide this particular service, again, the costs are covered by this particular component. They can find an application at the Suicide Prevention Coalition website, which is RIVCOSPC.org or rivcospc.org. Right, you can go ahead and move on to the next one. The next component is innovation. Innovation is unique, and that is not designed to fill service gaps, but rather to advance knowledge in the field. PEI projects are like big research projects. Thinking back to your school's days, they are time limited, 3 to 5 years, and they have to have learning goals embedded in them. Even though the state sets aside Riverside County's innovation dollars, we have to prove that our plan is actually innovative before they will let us have access to those dollars. So there's an additional state approval process that we have to go through in order to be able to access those funds. Riverside's most current work plan was the Tech Suite or Help at Hand, which just expired in February. But a new plan has been approved by the state, our Eating Disorder Intensive Outpatient and Training Program. The link there on the screen gives you actual link to the plan brief that was approved by the state. We have already started the process of meeting with the folks to begin implementation on that proposal. So we hope to do the actual, we're doing pre-planning right now and hope to do the actual kind of beginning stages of getting things more moved towards that project in July, beginning with the new fiscal year. Go ahead and move on to the next screen. But I'm going to give you some updates from the Help at Hand Collaborative, which just, as I mentioned, just expired in February. We had 5 years to be able to look at essentially how smartphone applications and modern technologies can support people who are in behavioral health recovery. Lots of good stuff came out of that project, many of which will now be integrated into our overall service system and funded in other parts of the plan. One of those is the Take My Hand Live Peer Chat, which provides live peer-to-peer chat interface using real-time conversations for people seeking non-crisis emotional support. Take My Hand was recognized as a California State Challenge Award recipient. The total number of Take My Hand chats through most of 2023 was over 1,600. We also are currently implementing a pilot using ASL video chat with 2 deaf peer chat operators to offer additional supports to the deaf community. Another project within that Help at Hand plan was La Clave, La Clave means the key in Spanish. It is a culturally informed program for the Latinx community that helps family members understand the initial symptoms of serious mental illness, particularly those symptoms of psychotic disorders. It uses cultural references as teaching topics for the general community. Researchers indicate that earlier the intervention after somebody has a psychotic break that they're able to get into care, the better the overall prognosis for their lifetime. So it's typically within about 4 years that somebody goes from psychotic break to their first treatment. And research indicates that if they're able to get care within the first 18 months, it significantly improves their prognosis. So the more family members, community members are able to recognize these symptoms as illness, the goal is to then be able to get people access to care earlier. La Clave content was integrated into the Take My Hand mobile app and website, and most recently, Univision in Espanol and NBC Palm Springs reached out to collaborate with Help at Hand to promote La Clave in the desert region. And you can move on to the next one. The next component is workforce education and training, or WET for short. WET doesn't have any separate funds anymore like it did when the component was first introduced. Those funds expired in 2018, but WET plan can still be funded using a portion of the dollars out of the CSS component. The primary focus of WET is to recruit, retain, and develop the public mental health workforce. That the authors of MISA understood that all of these plans on paper look really good, but if there aren't any people to actually be able to implement them, then they are just words on paper. So they put a lot of effort into what do we need to do to develop the workforce. So you can see the work plans within Riverside's WET plan itself. Goes everything from being able to look at training and technical assistance through financial incentives for workforce development. And if you go on to the next slide. An update in our WET plan includes the WET internship programs continue to be one of the largest behavioral health internship programs in the Inland Empire. In the past academic year, our graduate internship field and traineeship, what we call the GIFT program, coordinated internships for over 37 master's and bachelor's level students countywide. Over 51% of that cohort was bilingual. 46% of that threshold spoke the threshold language of Spanish. Interns become a primary candidate pool for hiring new department therapists. And as most of you probably are aware, in most fields, workforce shortages are difficult. That includes in our current workforce with therapists. Last year, of all the interns that applied for positions, nearly every single one of them was hired. So they are a great candidate pool to be able to keep our system moving forward. All right, go ahead and go on to the next slide. The last component in MHSA is Capital Facilities and Technology, or CFTN. And CFTN, like WET funds, had a time-limited amount of their specific allocation, and they hadn't have a specific allocation since 2013-14. But again, a portion of CSS dollars can be drawn down in order to address new work plans. The primary focus of CFTN components is to improve the infrastructure of public mental health services. This includes actual physical buildings and electronic programs like our electronic record. Some current projects in our CFTN plan include the Mead Valley Wellness Village, The Place, which is one of our homeless centers here in Riverside. It's being renovated and it has a new renovation date for the end of this year. And then the one I'm going to talk about in a moment is the Franklin Avenue Adult Residential Facility, a new augmented board and care that's being built here in Riverside. Go ahead and go on to the next slide. Renovation has begun on an augmented adult residential facility on Franklin Avenue in the city of Riverside. When completed, this facility will provide approximately 81 beds with integrated on-site full-service partnership services. The facility is expected to open in December of this year. The facility will provide a level of service comparable to the department's existing adult residential facility located in Palm Springs that many of you might be familiar with, called Roy's Desert Springs and Windy Springs Wellness Center combination. So This level of care, augmented board and cares, is one of the areas in which BHSA's bond measures was trying to address, because these kind of more higher levels of care have been diminished over a course of time and are desperately needed, especially with California's population. And this allows us to have that step down level of care so that folks can get out of acute levels of care, but still have the support necessary to integrate into the community. That completes my updates on the actual MISA plan itself. So what's the next things that you can expect? Well, the next things you can do in part of this process is our public posting and public hearing process. This month, I'm scheduled for it's going to be either the 19th or the 22nd. So that's either a Friday or a Monday, depending on my timing. We will be posting the draft plan on the department's website. This allows the public an opportunity to read the plan and to then comment on it. It has some feedback forms, electronic feedback forms that folks can send in feedback. And we also make available a hotline. So if folks who don't actually want to write out their comments, they can call in and leave those instead. And then following that 30-day posting period is a public hearing process, which allows folks another opportunity to provide their feedback and learn more about the plan. So I'm going to go ahead and go on to the next slide. So what does a public hearing look like? We have two versions of a public hearing. Most of that came out of a hybrid that we learned during COVID restriction. During COVID, we couldn't meet in person, so we had to come up with new ways of getting folks the information and participate in this process. And what we did was we came up with a process called the Public Hearings in Your Pocket. Essentially, we created videos in both English and Spanish. The English video has ASL embedded interpretation that folks can access the informational part of a public hearing 24/7 over a 2-week period of time, and they can look at it again at any time they want to. So instead of having to go to a public event, which was usually one event in one location at a certain time of day, they now could look at those public hearing videos anytime that they needed to during that 2-week period of time. And they had multiple avenues to be able to give us feedback. Again, there was an electronic feedback form, there's a phone number, and for those who wanted so, we would even send them handwritten feedback forms with a self-addressed stamped envelope that they could be able to send that back to us. So those became very popular. We got a better participation in our virtual public hearings than any of our in-person public hearings. So even moving forward past COVID, we just decided to keep them so that we will have both the virtual public hearings going on at the same time that we have the in-person public hearings going on. Go ahead and move on to the next slide. So what does an in-person public hearing going to look like? There are 3 of them, one for each one of the service regions. The cities in which those will be held were determined by each of the regional mental health boards. And I just got today the final list of those proposed. The contracts are pending for the locations, but we believe we have them. The public hearing for Western region will be held at Moreno Valley Conference Center on May 28th. The public hearing for the Mid-County region will be held on May 21st at the Hemet-Scar Conference Center. And the hearing for the Desert region will be held in Palm Springs at the Mizell Senior Center on May 23rd. What these do is they allow folks to come in and get a presentation that'll be very similar to what's on the videos, a presentation held by the Behavioral Health Commission. The hearing is conducted, and they were able to then get the information and provide in-person testimony. We also precede these public hearings with what I call forums. So about for 2 hours before the actual hearing, folks can come in, and we have refreshments and stuff, and they can come in and they go to education stations for each one of those components, learn more about what's in the plan from the actual MHSA administration, and that gives them some information to then be able to provide testimony from. So they have some, they're informed before going up to the microphone, should they want to be able to provide oral testimony. And I think that covers that part. Go ahead and move on to the next slide. So people are asking me, okay, I give you this feedback, what do you do with it? Well, first, it's important to note that all of the Behavioral Health Commission, which is volunteers appointed by the Board of Supervisors, so that there's citizen oversight for the Behavioral Health Department, they conduct the hearing. By regulation, they conduct the hearing. So they hear all of your comments. Then after all the comments are received, they are documented. And I meet with the Behavioral Health Commission and they compose responses to each one of those comments. And those comments and responses become a chapter in the final plan. That final plan is then sent to the Board of Supervisors for full review, including that chapter. And then it is submitted to the state, who also reviews it, and it's posted on the RUHS website. I then compose a feedback summary and provide that to the executive office. So our execs have a summary of all of that feedback. Then in practicality, how is it applied? Well, smaller recommendations can be more readily adopted, but larger recommendations that sometimes require larger community support, meaning we need to hear from more stakeholders, not just one or two, that this is what they would like to see and have that change. And then those kind of changes can take time to be able to be developed. So sometimes you're not going to see something immediately implemented. It will be something that has to develop over a course of time. All right, and go ahead and move on to the next slide. This is my team. So if you're wanting to get some email notifications regarding the upcoming public hearings, or to get additional information regarding any of the programs or services that are currently within those teams that I manage, you can get on our distribution list and they will send you out those emails and those distributions just as they do everyone else. So the top one is the main misadministration number, and then that's my information. I have a PEI manager, Diana Gutierrez, that's her information. I have a workforce education and training manager, that's Nisha Elliott. And then the innovations manager is in recruitment, and I'm currently fulfilling that role. So those are the contact information for that program as well. Go ahead and move on to the next slide. All righty, so that's the end of the MISA portion of today's presentation. So I'm going to go into the BISA portion of today's presentation, but I want to stop here for a moment. I know that was a lot of information. So I just have anybody had any initial questions on any of that stuff, I'm welcome to entertain those now, or you can certainly wait until we have full end of it if you'd like to. Anybody currently have any question, comment? Maybe I should open up the chat here and look at it.
It looks like we have a hand up from Gina.
Go ahead, Gina.
I'm wondering, could you please repeat the phone number for the mental health crisis team?
Most certainly. It actually takes you to the local help center, the same crisis line that if folks are in distress and they're calling just because they're in distress. The department's overlapped. It already has a contract with that agency. So it's overlapping somebody who's already receiving crisis calls as an agency that can then essentially triage those calls to make sure that they are connected to the right help-seeking agency. The number is 951-686 and then HELP, help.
Thank you very much.
You're welcome. We also have a flyer on that. So if folks would like that, we can make sure we get that to the secretary and she can just distribute it in an email distribution. Any other questions before I move on to BHSA? Just making a note regarding getting the crisis flyer. Oh, thank you, Marielle. Very helpful, see? Do your job well, and A+. All right, I'm going to move on to BHSA. People have lots of questions, and so do we actually. As you'll find out, there's a lot of unknowns still because the state is currently, hopefully figuratively, writing some refinement language and some additional practical follow-up regulations so we know how to apply it a little bit better. But essentially, the Behavioral Services Act, the one that was voted on and approved, actually had two components. The Behavioral Services Act itself, the one that will go into law and legislation, and it also had a bond measure that allowed for some infrastructure development around more acute levels of care and some housing. And so some of the housing was language was had some set aside specifically for veterans, but most of the money in the bond measure went to developing out the more kind of, I'm going to call it higher levels of care in mental health. So everything from like acute hospital beds, augmented board and cares, what are called Institutes of Mental Disease. It's a terrible name, but we inherited from the 1960s. IMDs for shorts are kind of like nursing homes, but for folks who have mental health needs. And all the way up to state hospital beds. These have all been diminished over time. And so the idea is to build those out so that we have a full continuum of care that folks can have access to. Outside of the bond measure, though, becomes this kind of new replacing legislation from MISA. So all that stuff that I just presented on, that was Mental Health Services Act. The Behavioral Services Act will replace that. And so that's what the heart of this legislation is. Even though it has passed as a proposition, it does not become law until January of 2025. And the legislation itself has embedded timelines to help counties kind of transition into the new plan, because it will take a lot of changes. As my colleagues at the state say, this will be the largest change in behavioral health legislation that we will see in probably our lifetimes. So it is a big shift. And it will take, it's like steering that ship midstream. So it's going to take a bit of effort. So the first new plan for under BHSA is not due until this current MHSA 3-year plan expires, and that will be in July of 2026. But we got to make all those changes before July of 2026 in order to have that plan ready. It changes the components from 5 components, those 5 that you just heard, to 3 components. And those 3 components are housing, FSP, or full service partnership, and behavioral health services. They updated the language of the act to ensure that it's behavioral health services, not just mental health services. So they included substance use disorder services as a part of the focus of the act. It has a strong focus on looking at the unhoused and on youth. I'll mention that in the next one. Go ahead and move on to the next slide. BHSA didn't, what 2 components that are lost? Yeah, well, actually we lose, none of the components cross over. So the 5 components under MISA are CSS, community service and supports, then prevention and early intervention, and then innovation, and then workforce education and training, and then capital facilities and technology. So you can see none of those components neatly cross over. There are elements of those components that cross over because housing was in CSS and FSP was in CSS. They're just getting their own components now. I'm going to talk a little bit about what happened under prevention and early intervention, and then what happens then to the needs that are in those other components I'm going to talk to in a little bit later. They're integrated somewhat into this current structure. They just don't get their own component anymore. They're kind of like sub-elements of the other components. So the first thing to look at is BHSA didn't just reform MHSA. It reforms how behavioral health funding is planned, data, and reported. It says that essentially, even though each one of the funding streams that funds behavioral health will remain as separate funding streams, like we have federal match dollars from our Medi-Cal billing. That's one of our biggest funding sources. there are what called realignment funds from 1991 and 2011. Those are funding streams. We have some county general funds. There's money from grants. There's a list of things where you get a little bit of funding, some more than others, in order to be able to fund behavioral health programming. Each one of those have their own reporting structure. Now, BHSA puts them all in one book. It says all of those funding streams are going to be reported in one report. So not only BHSA funding, but realignment funding and grants and county general funds will all be in one reported document. BHSA also creates greater state oversight and approval. So previously, counties had more independence on what services and programs they could develop under MHSA. They have fewer options under BHSA. The state will essentially create a menu of options that the county can choose from. The state will also create metrics for the measurement of the success of those programs. And so those haven't been released yet. But it will say, like, it will determine by these metrics what success looks like from across the state, not individually in each county. The legislation was written very quickly and it had amendments to it. And so there are gaps in it. And so they acknowledged, even after it was written and put onto the ballot, it would need refinement amendments. It would need further amendments to be able to refine its practical application. That's the reason why there's still a lot of unknowns, because we don't know what that refinement looks like yet. So we have a lot of outstanding questions that we need to know because they don't show up currently in regulation. The Department of Healthcare Services will be tasked with creating the corresponding regulations that allow us to practically apply, like in the everyday, how are we going to do this, practically apply the actual law itself. Go ahead and move on to the next slide. So the first component is housing. It receives 30% of the BHSA total allocation. So going back again to that 1% tax on people who have incomes over $1 million, and that tax structure doesn't change, just how they divide up those tax dollars under this particular revenue source now will look like this under these components. So 30% of that revenue will go to this housing component. It is primarily focused on the chronically homeless, and primarily on folks who have been living in encampments. It's a housing first model, and that housing may include recovery housing. So for folks who might be in like substance recovery. Up to 25% of the dollars under this component can be used on new capital projects, new housing developed capital projects. But to utilize the funding for capital projects requires DHCS approval. So all those housing projects and plans have to be approved by the state. The dollars in this component cannot be spent on services or supports to people who are unhoused or newly housed. So currently in our housing program under CSS, we also embed our housing supports. So like case managers, therapists, those other kinds of supports are under the housing component under CSS. Under this housing component, they can no longer be funded that way. This component has to go for physical housing, either a structure or like rental assistance. The supports for people who are newly housed or unhoused have to come out of the other two components. And go ahead and go on to the second component. Second component is a full service partnership component. I mentioned a little bit earlier what that was under the CSS component of MHSA. It's essentially that same service. It just now gets its own component. 35% of the total funding allocation of the BHSA total allocation will be for this FSP component. FSPs are, again, those 24/7 high-intensity therapeutic and case management programs for people who generally have experienced the greatest consequences for untreated mental illness. It requires evidence-based practices, including assertive community treatment and forensic assertive community treatment, individual placement supports for employment services. These are specific models, evidence-based models, and high fidelity wraparound for youth and families. It requires assertive field-based initiation for substance use disorder services, including medication-assisted treatment, so medication-assisted treatment in the field. And DHCS, the Department of Healthcare Services, will develop again the metrics that will indicate when somebody needs to be in an FSP and when they are well enough to step down out of an FSP. And move on to the next component. The last component. Behavioral health services component. The behavioral health service component is like what I like to call the kitchen sink component, because this is the everything else goes here component. It represents 35% of the total funding allocation. It's important to note that even though a lot of the things that were in those MISA components can be funded under this, it does exclude some specific services from that were currently funded by MISA, and I'll go over those in a second. These services require a new subcategory called early intervention programs, and 51% of the BHS funds must be on early intervention programs. So that takes the PEI component as we currently know it and kind of cuts it in half. It takes away the prevention part and just makes it the early intervention part. It does redefine what early intervention means. So under MISA, early intervention had one definition, and under BHS, under BISA, it has a different definition. Early intervention programs under BHS may include services that prevent, respond, or treat behavioral crises, including like suicide prevention. 51% of early intervention funds must focus on youth under the age of 25. But BHSA has removed some things from the PEI MISA component. It's removed all references to stigma reduction, and it's removed county population-based prevention. So we had a lot of prevention services that were geared specifically to like underserved cultural populations. It removes those because they're going to put them at state level. And I'll talk a bit more about that in a minute. So we don't know what those population-based prevention programs will look like moving forward until we get better refinement language from the state regarding what we're supposed to do with them in terms of funding. It expands outreach to urgent cares, hospitals, emergency departments, and schools. So it's giving us a wider breadth of partners that we need to partner with to be able to reach behavioral health, education, and early intervention. And then those other components that were asked, what happens to them? Workforce education and training, capital facilities and technology and innovation. Those have to come out of this section, barring some very specific regulations, like again, housing capital can come out of the housing, capital projects can come out of the housing section. But if we were going to build a new clinic, it would have to come out of this section. Innovation programs can be across any of the components, but they have to be funded out of this one. Workforce education programs at county level have to come out of this one. The state has dedicated some funds out of BISA dollars for workforce initiatives. It's created an innovation partnership fund, and it's indicated that it will centrally run population-based prevention. We just don't know what that looks like yet. So we don't know if its population-based prevention programs are going to be like campaigns that we subscribe to, or if they're going to be like a set of granted dollars that will allow us to apply for a certain portions of the dollars. We don't know that yet. They're still working on those things. I think, yeah. Okay. And that's kind of, again, the snapshot of that particular component. And go ahead and move on to the next one. So what happens to the planning and reporting? I've mentioned some of those structural changes already, but starting in July of 2026, we have a new 3-year plan format. All funding sources, again, will need to be included in that planning document. VISA expands the stakeholders that we have to partner with in order to be able to write the plan to more regional partners. So it includes our managed care providers, our local health jurisdictions, and we have to work with the 5 most populous cities in the county. And so for Riverside, the current census data would mean that the city governments of the city of Riverside, Moreno Valley, Corona, Murrieta, and Menifee. So more people are involved in that process. But instead of this becoming just a stakeholder process that as we know it as an annual event, we only have to do that for the 3-year plan. So what I'm doing right now on this kind of process, that would only be required for 3-year plans, not for the annual updates, the little annual updates in between the progress reports. And then there's a new accounting and reporting document. Before there was an accounting document, we just had to put the MHSA dollars in the accounting document. Again, now we have to put all of the county funding documents for behavioral health in one document, and it includes some additional data points. It includes, we have to have like service utilization rate data and reducing disparities data, and some data on workforce development has to be in that reporting document as well. Go ahead on the last slide. I'm right on time too. I'm so proud of myself. That's the end of the full presentation. I like to call it, giving you a presentation with a fire hose, because it was a lot of information, I know. And so I thank you for inviting me and having me here today. And I realize it may bring up a lot of questions. I have about 10 minutes for any additional questions you may have right now. And you're welcome, again, going back to that slide that has my contact information on it. Should anything come up as you're thinking about it, I'll be happy. You can send me an email. I'll be happy to do my best to answer whatever questions you have if something should come up later. So does anybody have any additional questions right now that I can try to help clarify? Yeah, just as stunned as I was when I got all that information. I was just like, what? It's a lot to comprehend. And again, we're gonna have to start working on some of those changes. We're actually started working on some of them before, in anticipation of it potentially passing. And now becomes the harder part. It's the actual knowing what the map looks like and then steering the ship. Anything coming up for folks? A lot of folks will ask, what's gonna be taken out? And we don't know exactly what's at jeopardy yet, because we don't have that refinement language yet. So it's really hard to begin planning kind of reshuffling programs under funding sources until we know what the definitions of those regulations are, so we know where to reshuffle them. Are some programs potentially at loss, can be jeopardized? Potentially. I'm not gonna lie, you can't reshuffle a budget this large and then restrict it without some things potentially getting lost. If there's nothing else, then I'll give you back to your day.
Thank you, David. And folks can also email coc@ribco.org and we'll forward it to you.
Okay, and I will make sure we get you that flyer so that you can distribute that. And you can
Thank
also
you.
distribute this PowerPoint if folks want it. It has all of my instructor's notes in it. So if for some reason you weren't able to write all that down, all of my notes are attached to the slides.
Perfect. Thank you so much. We appreciate it.
You're welcome.